there's no niche visible, and this was a laparoscopic repair. Next slide. This is basically an algorithm. Is the patient symptomatic? If fertility is desired, you assess the RMT. If greater than 2.5 millimeters, roughly between 2 and 3, you can consider hysteroscopic resection, versus if it's very thin, to reduce the risk of bladder injury and uterine perforation, consider other closure techniques. Next slide. This I'm not going to go through, but I think it's an important article to review with regards to looking at the strengths, weakness, opportunities, and threats, the analysis of what we already know in terms of diagnosis and management. And what I'd like to point out is that, we should increase the awareness of isthmus seals, not just amongst patients, but also providers, and just know that ultrasound is readily available and it's something that can be easily diagnosed with or without contrast. Next slide. And in conclusion, we know that cesarean section rates are increasing, and so will the morbidity. It's important that we identify symptomatic patients and those who are at risk for obstetric morbidity. Standardized methods of measurement and documentation are now available. Those may be modified in the future, but it's important to use those guidelines, not just in clinical practice for communication, but also for research purposes. And gynecologists and gynecologic surgeons are well positioned to learn and perform diagnostic ultrasounds using these guidelines, correlate the findings clinically, perform the surgical corrections, and more importantly, participate in research to further the field. Next slide. Okay, continue. Thank you. All right. Thank you, Seth. I appreciate it. So we're giving a little bit more time to my colleague. Thank you.
Great talk. Thank you. That was awesome. It's so hard. I always run over. So, all right, I'm not going to talk much. Anyway, I don't know if I presented myself, but I'm Dr. Yvette Grossman, and I'm going to present our next esteemed speaker. She is internationally renowned. This is Dr. Caterina Exokoustos, who is coming to us from Italy. It's like 1:30 in the morning almost for her. Dr. Caterina Exokoustos is an associate professor of OB/GYN at the University of Rome, Tor Vergata, Italy. Her main areas of interest are endometriosis and adenomyosis, as well as benign diseases, including uterine pathology and infertility. She has contributed extensively in research. She's written a gazillion papers. Everyone knows her in the field of gyne ultrasound, and we are very lucky to have her here today. So, Dr. Caterina Exokoustos, please.
Thank you so much for the introduction, and I thank also AGL to give me the opportunity to share a little bit our experience. I hope that I will see my screen, but I don't know why it doesn't work. Let me see. Okay, you see the slides? Okay.
Yes.
Yes. And
yes, perfect.
And it's also my honor to be part of this group because I think that ultrasound and in gynecology, especially for surgeons, it will be the future. Both technique together will be the best for the management of the patient. At first, I want also apologize because my English is not the best one. So I hope that you understand all what I want to share with you and to explain all you the diagnosis of this pregnancy. I have no financial relationship to disclose. And I will I will explain you a little bit about the cesarean pregnancy, the definition, the ultrasound diagnosis, which are the criteria and the classifications. I will also show you what are the impact of these ultrasound findings on outcome and treatment. So at first, what is the definition? It is a pregnancy where the blastocyst is implanted near or over the tissue of the scar after previous cesarean section. And since the incidence of the cesarean section deliveries are increasing, it increases also this type of pregnancy, and it is correlated to a lot of complications, which include the placenta creta spectrum, but other several maternal morbidities, such severe bleeding, uterine rupture, emergency of the hysterectomy, and surgical treatment. So you understand that it is important to make a good diagnosis of this pregnancy. The incidence around 1 on 2,000 pregnancy and around 1.15% of all pregnancy after cesarean section. The incidence is, however, not clear and remains unknown because we have often underestimation and underreporting. And this misdiagnosis of an underestimation is due because mostly of the pregnancy were given as normal side pregnancy or miscarriage without intervention, or since sometimes this pregnancy progress, they are appearing as a development of a normal uterine cavity pregnancy, and often it is also that the early pregnancy scan is not be performed, and therefore the pregnancy implantation is not currently detected and underreported. Risk factors, as you heard before, as for the ISMO seal, the only risk factors mostly is the cesarean section. We don't know if there is a different suturing can be improved, but for sure we have not really understood risk factors. For sure it is not that if you have 1 or 2 or 3 cesarean sections, you are more at risk. It seems that the risk can be that the no stretching of the uterine low segment during breech presentation or term elective cesarean section, and also the interval between the 2 pregnancies, the present and the last pregnancy, can be also risk factors. As you heard before, and we are ultrasound fans, the first modality in imaging for doing the diagnosis is transvaginal sonography. It has been also suggested that you can do magnetic resonance, and as you see, this is a very recent paper that show you that magnetic resonance seems to be a better sensitivity and specificity for this type of pregnancy. But we have to understand that actually transvaginal sonography had a precise diagnosis, and it needs not additional imaging if it's accurate. And often the magnetic resonance is more expensive, but it gives us also the opportunity to give a very delay in diagnosis, and this is a very important issue against magnetic resonance. So the first thing is, when we are speaking about cervical and cesarean scar pregnancy, are ectopic pregnancy or inside the uterus, like cervical pregnancy or corneal pregnancy. So when we have to define what is the normal pregnancy, we have to see that it is a pregnancy inside the uterus, and this cavity is delimited by this line at the corneal tubes and internal os. When we are speaking about scar pregnancy, it means that it is outside this space, and it is inside at the level of the uterine scar at the level, and it can be partially invaded the myometrium or completely invaded the myometrium. And we have to distinguish this type of pregnancy from a cervical pregnancy. Often cervical pregnancy are not related to cesarean delivery, but remember, cervical pregnancy are inside the cervical canal and are lower than the internal uterine os. So you can see that if you have a ectopic cervical scar pregnancy, the cervical canal is free. When you have a cervical canal pregnancy, the cervical canal is full of the pregnancy and is at the level of the lower than the internal loss, and you can see the measurements from the outer internal os. Other features that can make the differentiation between other type of implantation of intrauterine ectopic pregnancy are obviously the inside the scar, but also at the level of the anterior part of the uterus, and also that the residual myometrium thickness is much more lower than in other type of pregnancy like cervical pregnancy. So just to reassume, cervical scar pregnancy is a pregnancy at the level inside this level at the scar, and invade the myometrium at this level, had an empty cavity and an empty cervical canal. And it can be round or triangular. It depends on the gestational age. It can have a thin myometrium, or it depends on the invasion. Vascularity can be improved, but we can have in pregnancy that can have or not the heartbeat. So it is important, as you heard before, that we have the measurements of the residual myometrium thickness. And this gives us the possibility to understand how much myometrium is infiltrated and how much it is the pregnancy is inside the niche, especially if the myometrium is very thin between placenta and gestational sac. And the other thing is that we can evaluate also the vascularity around and especially between the bladder and the cervical os, since it is very important, especially for the treatment. So you can understand that we have two types of cervical pregnancy. The one in which we have a myometrium thickening that is quite nice, and we have an implantation that is not only partial inside the myometrium and in the cervical isthmic space. And the other one where the implantation is inside the niche and goes inside and can reach the serosa of the uterus. And these are the two types that we have to distinguish. And it is important to understand which type we have in front by measurements and by looking at the invasion of the myometrium. And you can see very clearly these two types. Less than 50% of the gestational sac is inside the canal and inside the uterine cavity. More than the 50% of the sac is protrude inside the myometrium, and you can measure exactly this type of measurements of the thickening. I show you this again. Here's the sac, here's the measurements. The cervical canal is free, and the empty cavity of the uterus is also free. And to define better this protrusion inside the cavity or inside the myometrium, and there was a really recently consensus again, and which describe us more exactly this, and making two types of line. One is the uterine cavity line, which is the line that goes throughout the endometrium, and the correlation to this line of the gestational sac give us the possibility to see if it's more in the cavity or less in the cavity. The other line is the serosa line, which give us the indication when the sac goes outside to the serosa line. So we have then three options. The one is that the gestational sac is more inside the cavity, so lower the uterine cavity line. The other is that it is don't across the uterine cavity line, it's outside. And the other one is really the crossing of the serosal line. It means the bulging of the gestational sac outside the uterus versus the bladder. So you understand that now the scenario is quite different, because it is not only a cervical pregnancy. We have to differentiate it from the scar pregnancy. We have to understand if the largest part of the gestational sac is crossing or not the uterine cervical line. And then it is also very important to understand if it's crossing or not the serosal line, because these are the much more higher risk pregnancies for the scar. So just that a good diagnosis can give us really an impact on what is a risk and what is a lower risk. And therefore, these are now very recently given the steps that we have to make. The first differential diagnosis, and I want to repeat it, between cervical pregnancy and gestational scar pregnancy. That means here is the scar pregnancy, and the gestational cervical pregnancy is inside the cervical canal. Then we have also the differentiation between lower pregnancy inside the uterus, which are over the internal os. So these are very important issues. Second, we have to evaluate the measurements of the pregnancies, and I showed you before location, if there is the heartbeat, if there is the invasion inside the myometrium, if it's the measurements of the residual myometrial thickening, the protrusion to the of the gestational sac, and also the sliding sign between uterus and bladder. And finally, we have to classify it in type 1, type 2, and type 3, according to the crossing of the cervical line or the serosal line. So you can see how this type of pregnancy protrude versus the serosal line. And also it is important, especially for the surgeons who have to treat this early pregnancy, it is the position regarding the cervical or the uterine arteries, because it is very lateral, very near to the uterine arteries. It can also invade partially the parametrium and also the uterine arteries, and these are obviously pregnancy that are at very high risk for bleeding and for maternal morbidity. So once you have to do the diagnosis, you do the types. What is the counseling? What can happen? What is the evolution of this pregnancy? So it is that we know that we have a management that can be expectant, that can be medical or surgical. When we go to expectant management, what is the history or natural history of this scar pregnancy? Or it goes inside and protrude outside the uterus to the serosa, or it goes up and protrude inside the cavity, or it can grow inside the cervix or the lower segment of the uterus. When it protrudes inside the cavity, the gestational sac goes inside the uterus and uterine cavity, and the pregnancy can progress and go on. And just to show you how it happens, this was a pregnancy that we saw at 5 weeks. We have feared that it was a scar pregnancy, so we saw these patients again at 6 weeks. And then we are sure it was a scar pregnancy because the uterus cavity was empty and the pregnancy was not in the cervix, but it was a scar pregnancy. And if you can see, it was also here, you see the yolk sac. It was very early, so you don't see the embryo. And we measure also the thickening, which was quite nice and good. Then we saw the patient at 7 weeks. And again, you see the sac was a little bit longer, and it goes inside it starts to go inside the cavity, whereas the placenta lesion starts to go inside the niche and the scar. And what happens at 8 weeks, you clearly see that the sac was inside the cavity and the placentation here was inside and invade completely the myometrium. And finally, in 9 weeks, the gestational sac was completely inside the cavity and the placenta was in the niche and in the scar. And you can see at this level the uterine thickening of the myometrium. These patients delivered at 32 with C-section and had a hysterectomy for placenta accreta. And therefore, you understand that this type of scar pregnancy had different risks. And you can see that if the invasion is much more inside the niche and inside the myometrium, the high risk of hysterectomy and placenta percreta is very much. And therefore, to make this good diagnosis at the beginning gives us a possibility to counsel the patients for this risk. The risk of placenta accreta and the risk of abnormal placentation is an extensive problem, not only for the patients who go to hysterectomy and lose her fertility, but also for the surgeons, because these are often very difficult and tremendous event. So just to understand and see other types of what are the evaluation. And so you can see in this paper on 100 patients that had scar pregnancy, 55 had a progression and 13% of these had required an hysterectomy. But the others had or no motion or no cardiac beat or go to failed progression. But despite this, there are a lot of other problems and severe morbidity that are shown in these papers. And especially for hysterectomy, they show that the higher risk is when we have an infiltration of the niche at lower than 10 weeks, and also if we have a thickening of the myometrium less than 3 millimeters after 10 weeks. So it is nice to understand that when we have an ectopic pregnancy, we can have a pregnancy with or without a heartbeat, and it can be aviable, and the patients wish to continue the pregnancy with a high risk of placenta accreta and hysterectomy, which is higher for sure when the myometrial thickening is less than 5 millimeters. And if we have no beat, also there we can have some problems like complicated miscarriage in 13%. And also the problem that we can have in the first and second trimester are bleeding, are rupture, are hysterectomy, as well as for the third trimester, hysterectomy in 60% and a lot of problems in placentation. So very briefly, I want not to focus on the treatment, but just to show you that we have the management that we have to choose is dependent on what you see at the early pregnancy and to counsel rightly the patients. So the expectant management can be added a lot of other type of management which can stop this high-risk pregnancy at the beginning. And so you have to choose which are the pregnancies that have to progress or not in base of your first diagnosis. And you can try to make some treatment with methotrexate or local treatment with hysteroscopy, with uterine balloon, with dilatation. And I want not to go further with uterine artery embolization or with laparoscopy, which give you the possibility to really conserve the uterus and not integrate the future fertility. So The management is actually challenged and is widely not accepted in everyone, but we know that the first thing is every time an accurate diagnosis to evaluate the risk of the patient. So I will conclude that I think that every woman who had a cesarean section can have and can be considered at risk for a scar pregnancy, that transvaginal sonography can identify and classify this type of pregnancy, and these classifications are useful to assess the feasibility of the condition and also to predict some maternal risks and provide more information regarding prognosis and management. I also think that it is important that we do a screening test with in patients with cesarean deliveries, previous cesarean delivery for this pregnancy, because it is important to have an early intervention, and also if we want to go and have the progression, to send these patients to very high risk centers and multidisciplinary care. I want to finish with a debate. And this debate was between Professor Trimotrish, which we study a lot this type of pregnancies and consequences, and he is from the States. And he makes this debate on ultrasound obstetrics some years ago, saying that this scar pregnancy has not been to consider an ectopic pregnancy because it is inside the uterus and because it has potentially a live birth or the progression of the disease. The response to this was from Professor Jurkovic and in the other school from Europe, which said no, cesarean section scar pregnancy is an ectopic pregnancy because all ectopic pregnancy are potentially given a live birth, and it is a very good evidence that this pregnancy is associated to major complications, and it causes life-threatening and complication, and also can cause loss of fertility in these patients. So it is good to have an early intervention to treat the scar ectopic pregnancy. The response of the Professor Trimotrish and Goldstein, both from the States, are probably the word ectopic is not the right word for cervical pregnancies, for scar pregnancy, as well for cervical pregnancy, because these are not really ectopic pregnancy like tubal ectopic. So we have to worry and said this is another entity, and we have probably to change the nomenclature of this type of pregnancy. And I thank you for your attention.
Thank you. That was excellent. Brilliant.
I was thinking, I hope to be time.
Yeah, no, it was excellent time. And I apologize to everyone. I have a Siamese cat who always decides to join when I'm on, so you might hear meowing. That was excellent, both of you. Thank you so much. So I'm going to go to the questions. Actually, I do want to thank you, Dr. Exocoustos, for putting that up, because that has been the controversy whether it's a cesarean scar ectopic or a cesarean scar pregnancy. I wish we could vote and see what this audience thinks. I vote for the ectopic. What do you think?
I see a lot of pregnancies that goes on, so it is difficult to say this is not similar like a tubal pregnancy.
Yeah.
And probably to distinguish this from other types. So I agree a little bit with Trimotrish, with the Americans that said we have to choose a little bit the nomenclature, despite it is true that hysterectomies, you lose your fertility. Okay, you have to think about it.
Yeah. Okay, thank you. So first question is for Dr. Palmer. When you're measuring the adjacent myometrial thickness for a C-section scar niche, How far away from the niche do you measure? Is there an actual number?
You measure close to the niche. Yeah,
So there's
basically
no actual
at
like
the
number
edge.
that like they're asking, is it 10 millimeters away or is it
No,
just objective?
the recommendation is essentially at the edge of the niche.
Okay, thank you. What percent, so I guess this would be for Dr. Exakustos, what percent of accretas begin as C-section scar ectopics? That's a difficult question. So
I
what
don't know.
percentage of accretas do you think started out as C-section scar? That's a,
So you understand that not all the scars, this pregnancy goes on. If they progress, they have from 60 to 8% of placenta failure. So it's very high.
okay.
If they progress, so it's not all progress.
Okay. Actually, on that line, and you did say this, but I want to make sure that people hear this. If someone were to ask you, should all women who've had one C-section or more, should they have an early ultrasound, a screening ultrasound to rule out cesarean scar implantation?
I think, and not me, but a lot of papers, especially from the School of Pediatrician, not Cali, because Cali is an Italian researcher. They said that it is a screening test that has been done. Should be.
Okay.
So it is important that if you have a patient with a C-section, you do a scan at 6 weeks, 7 weeks.
Yeah. I mean, we do that when someone's had a prior tubal ectopic pregnancy, they always get an early ultrasound, right?
Yeah.
Right. So why don't we do that with cesarean scar? But yes, it's not a guideline in our country, and it's not a guideline in Europe either, I take it, or in Italy.
But you know that the most Italian, when you have a positive test, you go to the gynae. And the
Yeah,
gynae you have not to need to be a radiologist or you have your probe in your hand. So you put inside the probe and no more the finger because you don't see nothing with the finger. And you put inside your probe and you see the pregnancy.
right.
I think this is why we are here. We want to teach all the possibility to make this diagnosis and not only to the expert.
Right. So what Dr. Exakustos, because not everyone may be familiar, but in Europe, like in Italy, the physicians do their own ultrasounds. So if a patient comes in for their first OB visit, instead of using their finger to do an exam, they use a probe. But in the United States, we're not trained from residency to do that. And we have sonographers, people have to go and get an ultrasound. So it's a bigger deal. But that's why we started this advanced gyne imaging SIG to teach people. And that actually comes up to a question that was asked prior to starting this. Someone asked, how can fellows get more ultrasound experience? Dr. Palmer, since you're our chair,
Yes.
I know.
Well, I mean, it's a work in progress, and I think just the creation of this special interest group is a start. I definitely foresee, when you say fellows, I'm assuming minimally invasive gynecologic surgeons, but I guess it could also be, I mean, REI fellows have experience with scanning, but maternal fetal medicine specialists, they're the experts in obstetrical ultrasound. If I'm a gynecologic surgeon or I'm a gynecologist, I should also have that tool at my disposal and um, basically be an expert in ultrasound as well, right? So instead of sending a patient to radiology, a sonographer scans the patient and it's read by a radiologist. Not to say that it should be taken from radiology, but we have to own it a little bit more. And it's readily, it's cost effective, and it's more readily accessible than getting MRIs. So how can fellows get more experience? It depends on your institution, but that's one of the things that we're working towards. I personally think that advanced gynecologic ultrasound should be a part of minimally invasive gynecologic surgery fellowships. And that fellowship probably will be given a different name, complex benign gynecology, but the ultrasound component should be a part of the training. And so we have to take a look at training from different levels, from the residency level. When I was a resident, I went to the ER and I scanned patients, from the fellow levels to practicing for physicians. So I think it's something that was the impetus for us to start this special interest group, because it is an area that we need to take a little bit more ownership of and excel in that area and advance research, and use it for our surgical correlation, clinical correlation.
Yeah. So it's a
So,
diagnostic tool, like Dr. Exocousas was saying. In Italy, they just put the probe in,
yes.
and they know if right away it looks like it might be a
I
cesarean
don't
scar
know
patient.
if you're in the States, if you are in the emergency room as gynecology, you don't have an ultrasound machine near you, no?
They
So
do have an ultrasound machine, but they don't allow, the OBGYNs are not trained well enough in most
Yes.
programs in the United States to actually perform an ultrasound. I know. They only require 50 vaginal ultrasounds.
good training is to stay in the emergency room, and these are coming, you have the bleeding, you have all this, and
Yeah.
Yeah.
cases.
Yeah.
So this is good training.
Yeah, well, we're trying to change things within the next, this is why exactly what Dr. Palmer said. That's why we started this SIG. Someone actually on the chat commented that family planning fellowships, they do scanning, and that if there's MIGS fellows that also have a family planning fellowship in their academic setting, they might ask them if they can go and do some scans. It won't necessarily be for endo, but you'll get to see a lot of or if residents are interested in getting more experience. And we're all trying to, there's actually a fellowship, not a fellowship, I was going to mention it briefly, but GOHO is a society, an OBGYN society where fellows can apply and they can do a 1 month away fellowship anywhere they want, either in obstetric or gyne ultrasound, and they can pick who they would do it. So if someone wanted to apply to come spend a month with me or with Dr. Palmer in the States, and you win that, you get it all paid for, including like room and board. Okay, do we still have time?
I know that we're short on time, but just one comment I'd like to make is that gynecologic ultrasound today is very different than it was 30 years ago. There's so much advancement, right? So yes, we can do early OB scans and just check for a cyst, but as you mentioned, you can do ultrasound to check for endometriosis, deep endometriosis, bowel endometriosis, adnexal masses, malignancy versus not. There's just so much more that's there, procedures, tubal patency, 3D. So there's so much more that's there, and I think we really have the clinical background to be able to use that tool to help our patients, and not necessarily rely on more expensive imaging. Only use it if necessary, because it is complementary, but not necessary in all situations.
Right.
So,
I think with that we
thank you, everyone. And if you're from AAGL, you can join the SIG by emailing Seth Spirison. And thank you, Seth, for advancing my slides.